Welcome to this medicine masterclass in which we will be discussing prosthetic heart valves. Cardiac valve replacement provides substantial clinical benefits to patients with valvulopathies. Patients often either have an aortic or mitral valve replacement and frequently can have both valves replaced. And these valves can be metallic or tissue valves. However, as this is a major intervention, there are risks and complications that you should be aware of. So let's take a case and Mr. Jones presenting with shortness of breath. Let's see the findings that we'd expect on an examination in a patient who's had a valve replacement and have a case-based discussion. Now, on examination, if you inspect a patient who's had a valve replacement, you would expect a midline sternotomy scar. You'd also be looking for any signs of endocarditis, as these valves can develop vegetations. And you'd also want to look for any signs of vein harvesting in the legs or arms, which will suggest that at the time of a valve replacement, the patient also had a coronary artery bypass graft surgery. Bruising may suggest the patient is warfarinized, suggesting that the patient has a metallic valve. And they may also have anemia or jaundice resulting from mechanical hemolysis of blood cells. And as the valve technology has improved, this is becoming rarer. The precordium itself, you would expect a midline sternotomy scar, approximately 10 centimeters, and comment on whether it's a recent scar or an old scar, and whether or not the wound is healthy. You'll also note two inferior horizontal scars which were used for post-operative drains. In any patient who's had major cardiothoracic surgery, look in the neck for signs of a tracheostomy scar or any subtle scars suggestive of central lines, which would be used during anesthesia or suggest that the patient had a complicated post-operative recovery requiring intensive care. When you palpate in a patient with valve replacement or where the valve is working well, hopefully the apex beat will be palpable in the usual anatomical position. That's the fifth intercostal space, left midclavicular line, and should be normal in character. You may appreciate a metallic sensation on palpation. On auscultation, listen carefully to S1 and S2. S1, if you feel the pulse while auscultating, is heard during the pulse, at the pulse. And if that's metallic sounding, that would suggest that the mitral valve has been replaced. If you hear a metallic sound immediately after the pulse, then that's S2, and that would suggest an aortic valve. But if S1 and S2 were loud and metallic, and the sounds were heard during, with the pulse and after the pulse, that would suggest that they've had both an aortic and a mitral valve replacement. You can sometimes hear soft systolic murmurs over metallic valves. Peripheral findings: the pulse would be regular, the patient should not appear jaundice unless they've got excessive hemolysis, the JVP should be normal, and if the valve is now working, they should not have signs of heart failure, i.e. there should not be evidence of basal crepitations or peripheral edema. But you would be looking for signs of venous grafting in the legs or the arms, as well as any ecchymoses which would result from anticoagulation. So what are the differentials? The differential for a patient with a midline sternotomy scar and metallic heart sounds would be prosthetic heart valve replacement with or without coronary artery bypass grafting. So putting this together, Mr. Jones is a Caucasian man presenting to the clinic for a routine review. The patient was comfortable at rest, and I believe the gentleman has the following signs consistent with a prosthetic heart valve. On inspection of the precordium, there's a midline sternotomy scar measuring 10 centimeters. It's a recent scar with an erythematous border. The wound site is healthy, and I noted two similar horizontal scars at the inferior aspect of the midline sternotomy scars, which would likely have been used for post-operative drains. The apex beat was not displaced in its normal position, and on auscultation, S2 was loud and metallic, suggesting and was heard with the pulse, suggesting a mitral valve replacement. S2 was also loud and metallic and auscultated after the pulse and suggestive of an aortic valve replacement. The pulse was regular, no evidence of radial or radiofemoral delay. The patient does not appear jaundice or any signs of hemodynamic compromise or signs of heart failure. to investigate the patient if there was any indication, follow the B-fish model with bloods, fluids, imaging, special tests, and review all of the findings in the context of previous investigations. So the bloods, you'd be looking for signs of anemia or low platelets, U&Es assessing the function of the kidneys, the LFTs looking at liver function, as well as thyroid and cholesterol would be important. Assess the clotting to make sure that the INR is in the target range if the patient is warfarinized, and assess for signs of diabetes, and if there's any signs of endocarditis, perform aerobic and anaerobic blood cultures serially. You may want to analyze the urine for any signs of end organ damage or glycosuria. A PHS radiograph and echocardiography are key investigations to assess valve function, and they may require in future an angiogram if they're developing any signs of ischemia. The echo itself is used to assess cardiac contractility, the ejection fraction, and detect whether or not there are any regional wall motion abnormalities. In the context of prosthetic heart valves, the key role is to make sure that the valve surface area, the gradient, the velocity is all normal, and that there's no evidence of vegetations developing on the prosthetic valves. Complications of valve replacement: infective endocarditis. Duke's criteria, which has 2 major criteria and 5 minor, can suggest infective endocarditis. So the 2 major criteria are the presence of blood cultures showing classical organisms, whether that's Staph aureus, bovis, fecalis, viridans, or the Hasek organisms, and echocardiography demonstrating vegetations. These are major criteria diagnostic of infective endocarditis. The 5 minor, the mnemonic fever is used, so F is fever, E is evidence from blood cultures, V is vasculitic signs, Roth spots, Janeway lesions, or Osler's nodes, E is evidence from immunology, and R is the presence of risk factors. And to manage patients with valve replacements, they should be managed holistically, patient-centered approach with a multidisciplinary team, regularly reviewed in clinics using a conservative medical and interventional approach. You should always aim to optimize any comorbidities, treat arrhythmias or endocarditis or heart failure if that arises. In terms of the options, be aware that there are metallic and tissue valves. Tissue valves last for around 10 years. They don't require anticoagulation and so can be used in elderly patients quite safely, whereas metallic valves last longer and so can be used in younger patients but require lifelong anticoagulation, currently with teratogenic warfarin, which can affect young patients, particularly females who want to have a child. Transcatheter aortic valve implantation or percutaneous aortic valve replacement can be used in patients with higher risk cases. So, summarizing the difference between bioprosthesis and metallic valves, bioprosthesis is better for elderly patients, particularly over 65, used for mitral patients, and if they're over 70 for aortic patients. For those who cannot take anticoagulations, patients at high risk of hemorrhage or poor compliance with medications, and in particular women with childbearing age. Metal prosthesis can be used in younger patients, ideally those who are already on anticoagulation or prone to thromboembolism, and they last longer but will require lifelong anticoagulation. And this is a real issue, particularly if they present with melena. So clinically, if they're having a GI bleed, it's a clinical challenge to make sure that they remain anticoagulated for as long as possible, offsetting the risks. Otherwise, they're at risk of developing a cardiac thrombus, and that can necessitate further surgical intervention. Some of the options from a tissue valve which lasts 7 to 10 years, a xenograft, that's from a different animal, so porcine or bovine, homograft, usually from humans, cadaveric, aortic, this is the first choice ideally if it can be used. Metallic valves, there are a number of valves that you should be aware of. Some of these have been demonstrated on this slide here. So you have a Star Edwards, which is a ball and case device, but this device gives rise to a lot of hemolysis. A Bjork-Schilly valve is a pivoted single tilting disc which has laminar flow but a reduced incidence of hemolysis. A St. Jude valve has a double tilting leaflet, and a Medtronic Hall device seen on the end here has a tilting disc made of pyrolytic carbon, and it opens to 75 degrees for an aorta approximately and 70 degrees for a mitral valve to help laminar blood flow. Despite all of these advancements, there are still some complications that you should be aware of. The prosthetic valve can fail, can thrombose, the valve can dehiss, can become infected, and as a result of infection or thrombus can give rise to embolic phenomena resulting in a CVA or a stroke, hemolysis or bleeding from the drugs. So in summary, we've presented the case, discussed some common questions, some differentials, the investigations, talked about infective endocarditis, how to manage these patients, and the types of prostheses available. Thank you for attending this medicine masterclass.